ہمارے لوگوں میں بہت کامن ہے اور اس کی اپروچ نہیں ہے اور ان کی سمجھ نہیں ہے. تھینک یو سو مچ سر. اوور ٹو یو پروفیسر عامر عزیز صاحب.
جزاک اللہ الخیر. بہت بہت شکریہ. آپ نے کہاں سے کہاں پہنچا دیا. اللہ آپ کو جزائے خیر دے. میں بچوں کے لیے اسپیشلی یہ کہنا چاہوں گا کہ کووڈ کے دنوں میں ہم نے اللہ کے فضل و کرم سے ایک دن چھٹی نہیں کی. ہم صبح جاتے تھے اور بسم اللہ الذی لا یضر مع اسمہ شیء فی الارض ولا فی السماء وہو السمیع العلیم، یہ پڑھ کے ہم روٹین کا کام شروع کر دیتے تھے تمام پریکاشنز کے ساتھ. اور کووڈ کے پہلے سال میں 12,000 میجر آپریشنز اللہ کے فضل و کرم سے ہمارے ڈپارٹمنٹ نے کیے، جو ایک بین الاقوامی ریکارڈ ہے. کیونکہ جو باہر کے لوگ آتے ہیں، ہمارے پاس کئی گورے وزٹنگ پروفیسرز بھی ہیں، وہ سب حیران ہوتے تھے کہ تم لوگوں نے تو ہر ریکمنڈیشن کو غلط کر دکھایا. تو میں ان سے کہتا تھا کہ ہمارے پاس اللہ ہے، ہمارا اس پہ اعتماد ہے، اس وجہ سے ہم ہر چیز کرنے کے قابل ہیں. کچھ شروع کرنے سے پہلے میں یہ ضرور آج کہتا چلوں کہ میرا دل پھٹا ہوا ہے جس بے دردی سے یہ صہیونی اور یہ امریکی اور یورپین طاقتیں ہمارے مسلمانوں کو گاجر مولی کی طرح کاٹ رہی ہیں. اللہ پاک ہمیں کچھ غیرت دے دے. یہ وقت دعاؤں کا نہیں ہے، کچھ کرنے کا ہے. اور آپ دیکھیں ہمارے مکہ مدینہ کے امام بد دعائیں کرتے ہیں، کچھ عملی مشورہ نہیں دیتے اپنے حکمرانوں کے ڈر سے. اللہ ہماری فوج کو بھی غیرت دے، ہمارے لوگوں کو بھی غیرت دے، اور اللہ پاک اس مصیبت سے ہمیں نکالے. اگر آپ اسلامی تاریخ دیکھیں تو الملحمۃ العظمیٰ یہ بتایا گیا ہے کہ مشرق وسطیٰ سے یہ شروع ہوگی، عراق وغیرہ کے فلسطین کے علاقے سے، اور مسلمان گاجر مولیوں کی طرح کٹیں گے. اور صحابہ نے پوچھا آپ سے صلی اللہ علیہ وسلم کہ یا رسول اللہ کیا مسلمان بہت کم ہوں گے؟ آپ نے فرمایا نہیں، تم پہ گدھوں کی طرح پڑیں گے غیر مسلم، تم کم نہیں ہوگے، لیکن تم میں بیماری ہوگی وہن کی، اور وہن ہے حب الدنیا و کراہت الموت، کہ آپ دنیا کی محبت میں ہو اور موت سے ڈریں. موت تو آپ کو 7 پردوں کے اندر بھی آنی ہے. اللہ ہمیں قبول کرے اپنے رستے میں. میری تو دعا ہوتی ہے کہ اپنے رستے میں شہادت دے اور بغیر حساب کے جنت الفردوس دے. اب آج کا کام شروع کریں. It's very sad that in a developed country, in an old country, old civilization like ours, we have not been able to translate the medical science into our own language. All the developed countries in the world teach medicine in their own language. Japan, Germany, Scandinavia. But we have to resort to English. It's unfortunate, but there we are. Today's brief given to me by my brother, Professor Mulazim Hussain Bukhari, is about total knee replacement. This is a very, very common illness, and almost everyone suffers from it at some stage of their lives, especially at my stage of life. The common thought is that this is an operation of the bones, but the crux of the matter is that all the ligaments attached to this joint need to be balanced properly for the result of a knee replacement to be successful. So it's a soft tissue operation where you balance the collateral ligaments, the extensor mechanism, and then make appropriate cuts and replace the joint. So please remember that, especially for students. You can teach a monkey to do a total knee replacement, but he will have problems trying to balance the ligaments, and we'll discuss that in some detail. Ligaments keep the bones and joints straight, and this is the best example. And the more balanced the joint, the longer it will last. The first question a patient asks is, how long is the joint going to last? So the average is about 15 to 20 years if done properly. All the joints made by good renowned companies of the world, which are mostly from Europe and the United States, And now good Chinese companies have also come in the market, and they've managed to cut down the price of these people who just skin us in the name of research and development. So what is a painful knee? It's a stiff knee, and you cannot do your normal chores. You have problems walking, especially for us Muslims, we are unable to pray. That's why people say that pray as much as you can, and this is Maulana Rumi. You play as much as you can during your youth, because when your hairs grow gray, you will not be able to even prostrate in front of Allah. So make use of the time that Allah has given you before it's too late. What are the learning objectives of this interaction with you all? First, we'll discuss the indications of the total knee replacement, then the contraindications. For any medical procedure or medicine that you prescribe for a patient, you have to know three things: indications, the contraindications or side effects in the case of medicines, and the dose or the proper amount that you need to give to the patient. If you don't know these three things, you should not be in this business. So we'll discuss the indications, the contraindications, then how do you evaluate the patient before the operation? This is the crux. You need to select the right patient. For my younger budding doctors, medicos, please never operate for money. Operate for the special medical indication for your patients, and then select the right implant. Do not select the implant of the company that sends you for travel abroad in the guise of attending conferences. Unfortunately, the medical profession has a lot to answer for, because there is no free lunch. Even a lunch that a company takes you out to is paid for, unfortunately, by the poor patient of this country. What are the complications of the procedure that you've done? Because there is no procedure which is 100% safe. There is a known complication rate no matter where you are in the world. You must try and match the best centers in the world and do not cut corners. It's important to learn to say no, because you will be the only one who could answer it. You cannot kid yourself. And then I'm going to briefly tell you what Allah has given us in the form of Ghurki Trust Teaching Hospital, Department of Orthopedics and Spine Surgery. So what are the indications of total knee replacement? Arthritis or arthrosis, whatever you believe in, it is not actually an inflammation per se, because with inflammation, we join infection. It's an aseptic condition of the knee in majority of the cases, where the lining of the knee gets out of control and erodes the articular cartilage. And then the cartilage becomes like the roads in Pakistan and Muzaffarabad, with big holes in them, and it causes a lot of pain. And in severe deformities, in addition to swelling, you have malalignment. And you must all see these patients already. The x-rays are like this. The joint space is totally destroyed. In rheumatoid, there are no osteophytes, but the joint space is gone. And this is the deformity that I'm talking about. Look at this gentleman. His right knee is pointing outwards. It's called valgus. This lady below has what is known as bow knees, bow legs, because the medial joint, which is the case in majority of the patients, about 70% to 80% of cases are of osteoarthritis, which is a degenerative process. And please remember, 70 to 80% of load is transmitted through the medial joint. The knee comprises or consists of three joints. One is the medial tibiofemoral, the other is the lateral tibiofemoral, and the third is the patellofemoral. And majority of the load is transmitted through the medial joint. Thus, the bow legs that you see in this lady, this is the commonest form of deformity. They do not let it get to this stage in the West, and they offer medical help. And I firmly believe, my strong belief is that Allah is going to question us about what did you do with the skills and knowledge that I gave you? How much did you help my people? And we will be answerable for that. And if we do not leave a legacy where the poor patients of Allah are treated properly without looking at their pockets, we will be doomed. What are the other indications? Inflammatory conditions like ankylosing spondylitis, systemic lupus, psoriasis, gout, etc. And in our country, poorly fixed fractures by untrained or badly trained orthopedic surgeons and non-orthopedic surgeons and even non-doctors. It's a free-for-all in this country. There is no check, and Qaid-e-Azam made this country and he's still running it. And we get out of trouble by presenting Qaid-e-Azam. But this is one of the indications where the congruence of the joint is afflicted and it leads to early degeneration, and the patients get to the condition where they need a new knee. For the average age in the West, in our part of the world, the patients suffer the conditions 10 to 12 years earlier. So what are the contraindications? So to summarize indications, painful, stiff, malaligned joint with radiological changes are the indications. Contraindications are absolute and relative. Absolute if there is sepsis. In the case of pus in or around the joint, please never even think of doing a total knee, because I'll show you pictures later. Once the knee replacement gets infected, that's a disaster. And people have had to have amputations after infections in a knee joint. Any infection anywhere in the body, if the extensor mechanism is destroyed, the ligamentum patelli, if that is destroyed, if there is gross deformity and muscle weakness, paralysis like polio, etc., and an arthrodese knee, where it's painful, painless, and the patient is walking well but with a limp, and the patient demands a knee replacement, it's technically very difficult. So please learn to say no. This is the sepsis I'm talking about. Even if it's superficial, you cannot operate on this knee till this redness and infection disappears. This is the hyperextension paralytic knee with congenital deformities. The one on the right of the picture, they can be operated, but please look at the extent of the deformities and don't touch these patients with fancy joints. This is the arthrodesis I'm talking about, a solid fused knee, which is pain-free, but the patients now want flexion. So you please control your urge to put him to your knife. Please be very careful. What are the relative contraindications? You must have seen people with psoriasis, eczema, vascular malformations, unhealed wounds on the limbs. Even these are the conditions. Wait for things to settle down and only then operate. Otherwise, it's an asking for trouble in these patients. If there is ischemia, remember all wounds heal with a good blood supply. And if there is compromised blood supply, and especially these patients are elderly, please refrain from operating on these patients. If the patient has a poor healing condition, if he's hypoproteinemic, osteoporotic, please be careful. Atherosclerotic disease, neuropathy, a paralyzed limb, the healing potential is decreased. And if the patient is unable to cope with anesthesia and stress of the surgery, you should rather aim for a deformed limbed patient than a dead patient. So please be careful. The next step is to evaluate the patient. You cannot just offer a total knee to everyone. And these are the factors that you look for. You evaluate the patient for all medical condition, his family support, because after surgery, they do need rehab, and the social standing of the patient. The economics, please remember, after the knee replacement, you cannot squat. So the desi toilets that most of our households have cannot be used. So you need upgradation of the toilets, etc. And that needs money. You need evaluation of the diseases and comorbidities of the patients. The American Anesthesia Association has laid down criteria of patients, and you only need to operate or should operate in patients who do not have severe comorbidities, poor cardiac reserve, etc., kidney failure, liver failure. Hepatitis C is extremely common in our country. And we did a paper which was published that every elective case that we operate in our department, every third case is Hep C positive. So please be very careful. And then the anesthesia people should decide as to whether the patient is fit or not. And then you need to confirm if the patient is really in need of surgery, the patient's family has been counseled, the social and cultural setup has been looked up, and the economic details have been looked up. You evaluate for the disease the patient has, his pain, functional limitation, the deformity, how much walking aids does he use, does he have other systemic problems, even sore throat you should not be operating upon, coughing, any dental problems, ear discharge, dysentery, urinary problem, etc. You need to be very careful about them. And then the local conditions around the knee, I showed you pictures of inflammation, skin condition, blood supply of the limb, deformity, etc. And the status of the opposite knee and the joint above and the joint below, the hip and the ankle. You need to be very, very careful about them. We've discussed these, look after. If the patient has a prostate problem, sort that out first before you subject them to a knee replacement. Then you need to know the radiology. And please remember, if the movement pre-operative of the knee is severely restricted, then post-operatively, the results will also be compromised. One. Number two, the size of the thigh. If it's a fat Lahori thigh, then the post-operative movement will be less. Slim legs get better results post-operatively. So you get x-rays of the knees standing up, AP, the lateral, and if they can bend it beyond 90, a skyline view to see the patellofemoral articulation, and a long leg view, ideally, so that the axes of the hip, knee, and the ankle can be restored, and of course, a chest x-ray in all these senior citizens. Routine investigations like renal function, hepatitis profile, and the most important test is a urine for culture and sensitivity. Remember, these patients, and by the way, mostly they are females, have a high rate of urinary tract infection. So if they are infected, you should not be operating upon. And please get a colony count. If their bugs have 10 raised to the power 6 colony count, it's an absolute contraindication till it clears up. If it's less than that, give them antibiotics appropriately for 2 weeks and then go in and operate. ECG, echo, etc. you need to have before surgery. Then the anesthesia people are the backbone of this procedure. People are scared, in addition to the cost, of the severe post-operative pain that they used to have. But now the anesthesia people have developed tremendously. And the anesthesia team that we are blessed with at Ghurki is outstanding. They decide as to what investigations and what anesthesia the patient is going to have, an epidural or a spinal or a GA, and then pain control post-operatively. They give all kinds of blocks for the patients, and the blocks have to be such that they should not alter with post-operative rehabilitation. So we have a great team and it's brilliant. DVT prophylaxis is the norm in the West. We don't use it as much. We resort to mechanical prophylaxis with stockings, but low-dose heparin or prophylaxis with aspirin, etc., are the norm. Plus the antibiotics, which should be given before the tourniquet is inflated. And if it's a prolonged procedure, after it's deflated. You need a wide spectrum antibiotic to cover it. The goal of the operation is to make the patient functional. He should or she should be able to walk, attend to the normal chores of their life, Before the surgery, the patients have what is known as a penguin gait or a duck gait. Technically, it's called a waddling gait. They walk with their shoulders moving on either side, and because they cannot put weight on their limbs. So we need to get rid of that. And they've almost always tried everything conservative before they come to us. Please be wary of the non-steroidal anti-inflammatories, of their renal side effects, upper GI side effects, and never combine two non-steroidals for one patient. They must have had injections. You have steroid injections, you have hyaluronidase injections, and the current trend is plasma pheresis, purified plasma with they spin the sample and give them injections, PRP, or even ozone is given. And the latest fraud is the stem cell injections. People, especially coming from abroad, who are not even registered with the Pakistan Medical and Dental Council, mostly they come from the UK, and they charge millions of injecting the so-called stem cells, which have got no proven benefit. Be very wary of this. And if an injection leads to infection, total knee is out. So it's a game changer operation, and their quality of life is significantly improved. Just to show you the long x-rays that I mentioned, the hip, knee, ankle should be in line, and we have different measurements which we orthopedic people, the proximal femoral, the distal femoral, proximal tibial, distal tibial, these alignments, we have templates pre-operatively, and we plan the cuts accordingly. This is what the x-rays looks like, and it should be a weight-bearing x-ray. Remember, the patient hurts on walking. So it's pointless doing supine x-rays. This is a weight-bearing x-ray, and as we mentioned, 70 to 80% load is transmitted through the medial joint. Look at this. The medial joint space is less than half the lateral, and we draw the angles that I showed you and cut the bone accordingly. Bilateral, you remember that lady that I showed you with bow legs? This is what the x-rays look like. Even worse than that, people come very late, and mostly it's because of poor information and poor economic conditions. The patellofemoral joint is also gone. The medial joint is also gone. And this is what I'm talking about, a total knee replacement. And usually 2 out of the 3 joints are replaced. The femorotibial, medial and lateral usually are replaced. The patella, we do a circumferential denervation, and we rub the articular surface with a file, and usually you get away without replacing the patella. But in some cases where the patellar joint is also badly afflicted, especially in rheumatoids, you also replace the patella. I'll show you the pictures of this. And under 70 years of age, and in a relatively fit patient, we prefer to do bilateral knees in the same go. But this is controversial, and a lot of people do one after the other. Our theory is that it's one hospitalization, the cost is saved, they have no additional pain in the presence of additional pain blocks that are given by the anesthesia. So why not give this benefit of doubt to the patient? But it varies, and there's no hard rule that you must follow. Just to show you some pictures. And in our setup, when our trainees finish their training, before they are let loose on the people of Pakistan, mashallah, they've all done a knee replacement before they go into their full-time private setups. Now, what is the cost? This is the biggest off-putting factor. In Lahore, people charge up to 12 lakh rupees per knee. The cost of the implant is 3 to 3.2 lakhs per knee. In the Aga Khan in Karachi, it's anything between 12 to 15 lakhs per knee. In Ghurki, in our ward, it's 4 lakhs for one knee, 3.25 for the implant, and rest for the medication. No surgeon's fee. And all these places use the same implants made by mostly American companies like Zimmer, J&J, Smith & Nephew, Biomet, etc. So it's in our hands how much we skin the patients. And this is the reason why a lot of patients cannot afford to have this. I call it a life-saving operation because a deformed, painful knee prevents the patient even from going to the toilet pain-free. And anyone who's in pain all the time, and especially when they lie at night, the muscles relax, the bone rub together, and the pain increases. They have difficulty going to sleep. So it's in our hands as to how much we can do. In Ghurki Hospital, we do about 1,000 joints a year, out of which about half are knees, rest are hips, hemiarthroplasties, and shoulders, etc. So alhamdulillah, we have a 1-year waiting list. Apart from zakat patients, especially in the last government's time when funds were decently available in the government setup, ours is the cheapest in the country. And we have a 1-year waiting list for the patients. And the companies also give us at a lesser price than what they give the implants in the market, because we ask for no non-joint favors from them. This is what it looks like. There's no blood because there is a tourniquet which has been inflamed. And in the picture, you can see the patella, which is everted, and the tibia and the femoral component has been released. And then the fibula, the patella will be filed, and the articular surface will be smoothened out. Remember, all damage to the articular surface is repaired with fibrocartilage, which decreases pain quite significantly. Just to give you one idea, if you remember the old pictures, I'll show you them again. Look at this. The tibia also has a metallic component here and the femur. And in this, there is no metal in the tibia. This is the all poly implant where the tibia is totally plastic. It's much cheaper. But majority of our patients are reluctant to use it because it looks odd. Now, with the economic constraints of the National Health Service, especially in the UK, they have reverted back to this. Results have shown that this is as good, if not better, than metal back tibia. And I have patients whom we did this 22 plus years ago, and alhamdulillah, they're doing well. Remember, it's a significantly lower price implant compared to the metal back tibia. And for both joints, the patient saves 70,000 plus rupees just by using this implant. Now, this is the lady. See, she cannot even take a step before surgery. And almost all of them are walking with a walker. Our ladies don't like a walking stick or a walker. Look at her walk. She cannot even take one step. And it's one knee which is afflicted in this patient. And this side-to-side sway of the shoulders is called the waddling gait. And post-operatively, after she's had the knee replacement, look, she's walking unaided after 6 weeks. The shoulders are normal, and there is a significant improvement in the quality of life of this patient. This is what I'm talking about. This is diagrammatically, look at the knee with Pakistani and Muzaffarabad roads, craters on the articular surface, and this is what happens. And the white structure on the left is the medial collateral ligament. Similarly, we have the lateral. The cruciates we usually sacrifice, although there are posterior cruciate retaining implants, but we don't use it because a deformed, shriveled ligament is of no use. Then to complete the list, because it starts in the medial side, they have come out with a uni-compartmental knee, which is almost the same price as the bi-compartment, but it can be used. In our country, when there is a uni-compartmental joint, we usually do what is called a tibial osteotomy. If you look Below the top screws, there's an area where the tibia has been cut, and the last joint space on the medial side has been opened up, and it's been fixed with a plate. There are different kinds of plates. When the knee is pointing outwards or valgus, we have to do the femoral osteotomy. So instead of using the unicompartmental knee, we do this, and the results are comparable. The cost is extremely low as compared to the unicompartmental joint. So it's called a high tibial or a supracondylar femoral osteotomy. It takes about 3 months to fully recover. The West has become very impatient, so they go for the joint. But Alhamdulillah, our people, because mainly of economic constraints, still are willing to have this done. This is one procedure that we introduced in the country. It was originally designed by an Indian surgeon who was imprisoned for some problem, and he saw patients in the prison who used to be beaten up by the prison wardens, and their fibulas used to be broken. And he noticed that when the fibula was broken, their knee pain improved. So he devised this, where you remove a piece of the fibula. If you look at the x-ray, piece of fibula is missing. Usually it's about 2 inches below the proximal end of the fibula. You remove about 1 to 2 centimeters of the fibula. We combined it with an arthroscopic debridement of the knee, and this also gives significant relief. Although the results of high tibial osteotomy are better, but in this you can start walking the next day. And this is a procedure which needs to be considered too, and we've published this as well. So, indications, contraindications, methods, etc. What are the complications? It's inevitable that this will happen. The bane of our lives in this part of the world is infection. The accepted norm in the West is 1% infection in total knees. You can stretch it to about 2%. But in our part of the world, because of lack of discipline, poor operating theater facilities, inadequately trained people, no operation theater discipline. We have a crowd of spectators observing the procedure, whereas there should be cameras and the procedure should be projected in the classroom. So infection, and please believe me, this gives the surgeons sleepless nights. It will happen, so you should be prepared with what to do. Malalignment, if the implants have not been properly put in, that leads to problem. If the patella has been replaced or not replaced and there is maltracking, you will get patellar dislocations. Periarticular fractures, the bone near the joints have stress rises, and a trivial trauma can cause fractures. What to do then? And then there's a classical aseptic loosening, because all these implants have a given finite life. And depending on how well the structures have been balanced and how well the procedure has been done, the aseptic loosening sets in accordingly. So I'll just show you some pictures. Look, the patella is dislocated. It should be in the groove in the middle. And since the alignment has not been properly maintained, in this patient, the patella was also replaced, and it's now dislocated laterally. So you need to be careful. When you put the implant in, you need to check the alignment on the table. And if this happens, you need to realign the patella, unless the patient otherwise will not be able to bend the knee. And if the patient bends and this happens, they can fall down and sustain other problems. This is what I'm saying, the malalignment. Look at the knee on the left, it's dislocated. The one on the right picture, there are multiple fractures and the alignment is totally out. This is the metallosis. All these implants are cobalt, chromium, stainless steel alloys, especially the ones locally made for different things. The quality of the metallurgy is not very good. This is what you see after many years, or even after a year or two, if they have problems. This is the thickened tissue response to the foreign element. The infection, look at the wound that the patient has. This is the early sign of infection: redness, swelling. Patient comes to you with pain, even fever, and you need to act as soon as possible. You look at the pictures on your right, the joints are displaced. They've cut out of the bone because of the infection. The picture on the left shows you that if this happens, you need to operate, remove the implant and the cement with which you put the bone in, and then after curating everything out, we put a cement spacer in the two bones with antibiotics and give them external splint and wait for the things to settle down. Once it settles down, then you do special implants to remove the diseased bone, and only then the patient is able to walk. Sometimes it's almost impossible. So you cannot put in another joint, and you need to fuse the knee, or called arthrodesis. But you have to remember that this problem, it occurs, it is very unforgiving. This is the fracture. This patient had a total knee replacement, and a trivial fall caused the fracture in the supracondylar area of the femur. You look at the fracture line. So this needs to be fixed with special implants, or if the damage is more, you need to put implants with a longer stem in the femoral shaft, and that can get rid of this problem. So to recap: infection, malalignment, malrotation, fractures, periprosthetic fractures, and loosening without infection after a few years. So I'll summarize. Knee replacement is for patients whose quality of life is severely afflicted. They have pain, they cannot bend the knee, they cannot even go to the toilet. They use walking aids. And a lot of our patients have had multiple fancy injections at a tremendous cost. In places like Karachi and Lahore, these people who come with the stem cell, etc., injections, charge them as much as a total knee, and then they disappear. And our people we are all mental slaves. Anything which has USA, Europe, Australia, New Zealand attached to it, we think that is the best thing that happened to us, irrespective of whether it's a con or not. So these people come twice, thrice a year, for a week, for a month, skin people, pocket the money, and go back. And once the patient has complications, there is no one to look after that. So my advice would be, follow the doctors who are available here and do some research as to who is ethical and who's not ethical. So do the best thing, select the right patient, select the right anesthesia, give proper antibiotics, select the right operating facility, use all precautions, use the best implants available, and then make sure that the rehabilitation is good, and inshallah, you will succeed. You cut corners in this very expensive and difficult procedure, and you will regret it. Believe me, one infection is enough to give you sleepless nights. So when I was coming back from the UK, my late boss, Mr. Robinson, said, you must learn when to say no. You know your facility, you know your ability, and you know what you can offer to your patient. So don't kid yourself. Be honest. And for us, we have to be answerable to Allah as well. I have not seen anyone who has lived forever. The graveyards are full of indispensable people. So I'll just briefly give you a look at what we have. And we started from a scratch in 2002. And alhamdulillah, now Allah has given us this. These are the state-of-the-art operating theaters. All were made in Germany, and the Germans came and installed them in Pakistan. They have antibacterial walls, HMIS systems, the X-rays, etc., can come on the screen. The lights have a camera which are connected to the lecture room, and all students and in conferences, people can attend to them. There's a one-way traffic. Through the door on the left, the patient and the instruments enter. Once the procedure is done, To the cupboards on the right, there is a through and through door. All contaminated, used implants, sheets are taken out from there through the dirty corridor into the CSST. We have, again, a made in Germany, state-of-the-art CSST, Center Sterilization Depot, and no autoclave and Cheetle forceps to bring instruments. That is a no-no. And we have markers which tell us whether the sterilization has been adequate or not. And only when it's adequate is it handed out to the people. The dirty instruments come, they're washed, and then they go into the clean area where they're packed and put into the autoclaves with the markers on them. And once they're properly sterilized, they are stored outside the operating room, and each theater attendant brings a trolley, picks whatever pack is necessary, and these sterilized sets of instruments are available 24/7. We are the only facility in Pakistan which is operating 24/7. If a fractured spine comes to us and there are no comorbid conditions, we operate the same night. Remember, all spinal cord injuries have the best prognosis to recover if they are operated ideally within the first 24 hours. And alhamdulillah, we are doing it, and we have published it as well. And from the ward patients, no surgeon's fee is charged. And to give you an example, we do about 15,000 major operations a year. And this is our department, 250 beds. And the bed occupancy is almost 100%. We have 10 operating rooms like the ones that I showed you, all state-of-the-art with laminar airflows and state-of-the-art German equipment of Draeger company. We have an outstanding team of 27 anesthetists. Remember, surgeons are nothing without the anesthesia people. And they would operate, let us operate on anything. We say, Dafa 302 ko bhi Allah ke fazl karam se operate kara dete hain, and we hardly ever have table deaths. So we have 50 FCPS orthopedic trainees at any one time. We have produced 200 FCPS orthopedic surgeons to date, and we have had fellows from 12 countries who have come and done their fellowships at Gurki, and alhamdulillah, the only department in Pakistan which has this honor. We have 6 professors, and we don't fight with each other. We have 2 associate professors, 8 APs, 8 SRs, and about 100 paramedics and nurses. We've been declared the best department of orthopedics in Pakistan by the Pakistan Orthopedic Association. So alhamdulillah. And I'll stop with one more thing. Every single person in my department, from a first day house officer and resident to all the professors, are my students. There is no department like this anywhere else in the world. Alhamdulillah. So thank you very much once again. Thank you very much, Mulazim and my brothers, to helping us share our little knowledge with your team. We would be more than happy to collaborate with you in anything. If you want training for your people in orthopedics and spine, we are, alhamdulillah, only a telephone call away. And now if there are any questions, please fire away.
Thank you so much, sir. Thank you so much, sir. Before this, I will invite, there are 2 your students, professors sitting. One of them is sitting in Ladkana and other is sitting in Peshawar. Both are now. One of them is principal there. Professor Zamir Somro is there. Professor Zamir Somro, you always, I met you there in Ladkana, and I remember that you gave me the reference of Professor Amer Aziz. Can you comment about this?
Thank you, Professor Mulazim. Assalamu alaikum, Professor Amer Saab.
Walaikum
Assalam wa rahmatullah.
How are you, sir? Great to hear your great lecture. Mulazim Saab,
Thank you very
one thing
much.
to share, rather a comment. We in 2015 sent our young colleague to Professor Amer Saab for training in joint replacement. Are you listening to me?